Hello everyone. Today in this video we are going to discuss about one of the most common cause of cyanotic heart disease, that is tricuspid atresia. As the name suggests, tricuspid atresia means there is a atresia of the tricuspid valve. The mainly normally the heart consists of four valves. That is first is the tricuspid valve, that is mitral valve, that is right, that is left, then pulmonary valve, and there is aortic valve. So these are the four valves. Now the blood from the body comes from to the right atrium, then by the tricuspid valve it enters into the pulmonary right ventricle and then pulmonary artery and then goes to the lung, and after that it comes from the lung to the left atrium, then from the mitral valve it enters into the left ventricle and then from the aorta to the body. This is the normal physiology. In case of my tricuspid atresia, that means atresia of the tricuspid valve. That means there is a no atresia of the tricuspid valve. That means no blood which is comes from the body to the right side of the right atrium cannot go from right atrium to the right ventricle via the tricuspid valve, as there is a no valve and no passage is there. So for this, the blood from the right atrium is accumulated here and no blood enter into the right ventricle from this pathway. Then what may be the connection in which the blood can enter into the lung? So there must be some opening in the atrial septum. That means ASD or the large foramen ovale that must be present for the survival of any child. And this small foramen from which the blood from the right atrium enter into the left ventricle, and then from the left ventricle it's enter into the left atrium, then from the left atrium it enter into the left ventricle, and from the left ventricle there may be either presence of VSD, so either presence of VSD via which the blood from the left ventricle enter into the left right ventricle and then to the lung, or there may be, if there is VSD is not there, then blood from the aorta must go to the pulmonary artery via the PDA. So there must be presence of ASD or foramen ovale, large foramen ovale, and there may be presence of VSD or PDA for the survival of a child. So this is the main pathophysiology of pulmonary atresia, in which there is a left to right and also right to left shunt occur. Right to left shunt occur in the atrial area and left to right shunt occur in the ventricular area. So by this, there is the child is keep alive in normal after the child keep alive after birth. Now come to the pathophysiology of tricuspid atresia. Before going to the pathophysiology of the tricuspid atresia, we divided tricuspid atresia into two parts according to the presence of VSD and TGA. In most of the patient, the tricuspid atresia is present along with VSD or TGA. So tricuspid atresia divided into two different types of tricuspid atresia based on the presence of VSD or TGA. Now, tricuspid atresia along with VSD, the pathophysiology we discussed first, and after that, tricuspid atresia along with TGA, that means transposition of the great artery, we discuss then. In case of tricuspid atresia along with VSD, first the blood from the right atrium enter into the from the body enter into the right atrium. Then the presence of ASD, the blood enter into the left atrium, and the blood from the lung also enter into the left atrium. So huge amount of blood enter into the left atrium. It causes left atrial dilatation, and this blood enter from the left atrium to the left ventricle via the mitral valve, and there is a huge dilatation of the left ventricle also. So there is a left ventricular dilatation and also left atrial dilatation is there, and from there is a VSD, and this VSD, size of the VSD depend the blood flow from the left ventricle to the right ventricle. So if the size of the VSD is less, there is a small amount of blood flow to the right ventricle, and this small amount of blood enter into the pulmonary artery and then to the lung and then come to the heart. That means the such chance of cyanosis is much more if the VSD is small. If the VSD is big, that means there is a massive VSD is there, then the blood smoothly enter into the right ventricle and huge amount of blood enter into the right ventricle, causing increase of blood flow to the pulmonary artery, which causing small amount of decreased amount of cyanosis. So the size of the VSD depends the cyanosis in patient of Tricuspid Atresia with VSD, and this patient present with, if the size is much more in patient of Tricuspid Atresia with huge amount of VSD, then the patient present with a heart failure instead of cyanosis. Small cyanosis is there, but the patient present with a signs of heart failure as there is a dilatation of the pulmonary artery, and this huge dilatation of the pulmonary artery causing the failure of the left atrium, as there is a increased blood flow to the pulmonary artery causing pulmonary arterial hypertension, and this hypertension leads to heart failure of the left atrium. Now, in patient with tricuspid atresia with transposition of great artery, that means the aorta is entered from the right ventricle and this pulmonary artery is originated from the left ventricle. So the right blood from the body enter into the right atrium. This huge amount of blood enter into the left atrium via the ASD or PFO, that means patent foramen ovale. So there may be must presence of this PFO or ASD. Then this huge amount of blood and also blood comes from the lung, is huge amount of blood on the left atrium enter into the left ventricle, and this huge amount of blood in the left ventricle enter into the aorta via the VSD. So the size of the VSD again depends the blood circulation into the aorta. If the size of the VSD is much more, that means big size of VSD is severe or is big, then huge amount of blood enter into the aorta is causing or no decreased amount of cyanosis. Or if the VSD is small, then small amount of blood enter into the aorta and huge amount of blood enter into the pulmonary artery. So this huge amount of blood which is present in the pulmonary artery causing pulmonary arterial hypertension also, and is this causing the failure of the patient's left atrium and left ventricle also, and there is a minimal cyanosis. So this is the again the same pathology. If the VSD is high, then there is a decreased cyanosis, but in this patient, if the VSD size is much higher, then there is a increased amount of cyanosis, has huge amount of blood enter into the left aorta, has huge amount of blood enter into the aorta, and if the VSD size is small, then huge amount of blood enter into the pulmonary artery, which causing decreased cyanosis. So there is a disproportion. First, the VSD size depend the cyanosis. If the VSD size is much more, then there is a cyanosis is present small in Tricuspid Atresia with VSD. So this is the true discrepancy in this patient. Along with this, we must see there is a pulmonary stenosis. If the pulmonary stenosis is there, then the cyanosis is much more. If pulmonary stenosis is not there, the cyanosis is less. Now come to the different types of Tricuspid Atresia. So as we say, it is depend upon the presence of TGA and also the VSD. So first, Tricuspid Atresia is divided into two types. First is with TGA and without TGA. Most of the case is there is a without TGA. That means 70%, near about 70% patient having without TGA. So then among them, the VSD is most common. That means among the 70%, 51% having VSD, and that the VSD is among the 70%, 60% having VSD, and only 9% or 10% having no VSD. But The first is the presence of VSD. If that means Tricuspid Atresia with VSD, there is small VSD and PS, that means pulmonary stenosis is there. So if the VSD is small, so this is the left ventricle, this is the right atrium, this is the right ventricle. So blood from the right atrium enter into the left atrium, and then from the left atrium into the left ventricle, and then left ventricle there is a small VSD, that means restrictive type of VSD. So restrictive type of VSD causing small amount of blood enter into the right ventricle, and also small amount of blood enter into the pulmonary artery. And there is also PS, that means pulmonary stenosis. So if the pulmonary stenosis is there, that means small amount of blood enter into the pulmonary artery, and this is causing massive cyanosis. So the small VSD with tricuspid atresia with PS is present with cyanosis since birth. When there is a large VSD with no PS, that means the VSD is large. So if this right ventricle and left ventricle work as a single ventricle, and there is a huge amount of blood enter into the pulmonary artery. As the pulmonary artery pressure is low, so much more amount of more blood enter from the left ventricle to the right ventricle to the pulmonary artery, which causing increased amount of blood flow to the pulmonary artery, which causes no cyanosis or small amount of cyanosis, along with patient present with heart failure. So this patient present with no cyanosis or small cyanosis since birth, but after 4 weeks to 6 weeks, the patient present with heart failure when the pulmonary arterial pressure is increases. So why heart failure? As the pulmonary artery, the huge amount of blood causing pulmonary arterial hypertension, and this pulmonary arterial hypertension leads to backward failure of the left heart. That means left heart failure. The patient present with left heart failure, and no VSD. That means there is no connection of VSD, and this child will not survive after birth, because the blood which is comes from the right atrium to the left atrium to the left ventricle, which enter into the aorta, and then the blood is going to the from the aorta to the pulmonary artery via the PDA. So if the PDA is there, the child will survive. Without PDA, the child will not survive. So this is the drug dependent circulation. Everything is drug dependent circulation, but this is the most important drug dependent circulation, and the child present with cyanosis since birth, and the cyanosis depends, or cyanosis is increased after 3 days when the PDA gets closed. Now tricuspid atresia with TGA. This is the most common. This is 30% consists of this, and this TGA present with mostly the DTGA. That means dextro TGA. Dextro TGA means the aorta present right to the pulmonary artery, and in LTGA the aorta present left to the pulmonary artery. Now TGA along with the VSD, as I said, the VSD is massive. In TGA, every patient having VSD. See, every patient having VSD, and the VSD size is depends. If the VSD size is much more, that means huge VSD is there, and there is a pulmonary atresia. Then the blood from the left to the going to the uh, left, then going to the aorta mostly, and small amount of blood enter into the pulmonary artery via the PDA. So this is also drug dependent circulation. Now VSD along with small PS or dynamic PS, that means pulmonary stenosis. This patient present with just like TOF, tetralogy of Fallot. That means cyanosis when the child is crying or the child is having exercise, and VSD with no PS, that means no pulmonary stenosis is there. So huge amount of blood enter into the pulmonary artery causing heart failure. So if the PS is not there, the patient present with heart failure along with VSD, and cyanosis is less. Now the clinical features. As I say, it is a drug dependent circulation because the blood flow from the right to enter into the left via the ASD. The most must ASD is must there, or PFO is must there, and after that the blood which is present in the left enter into the right ventricle via the VSD. If the VSD is not there, then from the aorta it is going to the pulmonary artery via the PDA. So PDA must be there. If the PDA is not there, and also the VSD is not there, the child will not survive after 3 days of birth. The severity of cyanosis depend on the, as I say, the size of the VSD. If the size of the VSD is small, the cyanosis is much more. If the size of the VSD is big, then cyanosis is less. And also the pulmonary stenosis. So if the stenosis is there, the cyanosis is much more. If the stenosis is not there, the cyanosis is less, and the child present with heart failure. As I said, this is the only disease in which there is a right atrial dilatation along with left atrial and left ventricular dilatation. In other type of cyanotic heart disease having no or small left ventricular dilatation, but this patient having left ventricular dilatation. So when I do the ECG, we see right atrial dilatation along with left ventricular hypertrophy with left ventricular dilatation also. So echocardiography is the investigation of choice and also the diagnosis of choice. Now the treatment. So when patient present with you after birth with cyanosis, you have to do all the 4 limbs pulse oximetry. If the pulse oximetry is showing cyanosis, then you have to do the echocardiography. In echocardiography, you have to see if the patient having tricuspid atresia, and then you divided the Tricuspid Atresia into two types, that along with TGA or without TGA. That means with VSD, without TGA. So then after that, if you diagnose that is the case of TA, Tricuspid Atresia, then it is a duct dependent circulation, as I said. So you have to keep pattern of the duct. So by pattern, to make the duct patent, you have to do the give prostaglandin and agonist infusion. That means L-prostatin infusion to make the duct patent. And also if there is a small PFO, that means as I said, ASD or patent foramen ovale is must to keep the child survive. So if the PFO is small, then you have to do Raskine balloon arterial septostomy to make the PFO patent. So this is the two immediate urgent surgery and urgent medical management you have to do as early as child is diagnosed with tricuspid atresia after birth. So after that, you have to do the first is the primary surgery. After that, when the child getting symptomless and the child is having age, then you have to do the second stage of treatment, and after that, the third stage of treatment. That means the final treatment. So first, if in patient of tricuspid atresia along with decreased pulmonary blood flow, that means decreased pulmonary blood flow means there is a pulmonary stenosis. So this type of child without having TGA, that means no TGA is there, that means the VSD is there, and along with the pulmonary blood flow is decreased, that means the patient present like just like a TOF, tetralogy of Fallot. You have to do the immediate surgery, that means BT shunt, that means modified parallel thoracic shunt. After that, you have to do bidirectional shunt. What is bidirectional Glenn shunt? I will discuss later. And after that, you have to do definite surgery Fontan operation. What is this? I will discuss later. So the main pathophysiology is to keep the blood flow into the right side. That means the main pathophysiology of these three operation is to maintain blood flow into the pulmonary artery. So what is bidirectional shunt? As I said, that means as I said, there is a decreased amount of pulmonary stenosis is there. Decreased pulmonary blood flow means pulmonary stenosis is there. So if the pulmonary stenosis is there, the main we have to do increase the pulmonary blood flow to make the lung, make the blood enter into the lung, and this blood getting oxygenated and causing decreased amount of cyanosis. It is the main pathophysiology of this operation. So we have to make the blood flow increases into the lung. So as I said, this is the bidirectional shunt. What happened? The SVC, that means superior vena cava, is the superior vena cava is stitched with a right pulmonary artery. So the blood from the body enter into the superior vena cava, which comes to the right pulmonary artery and then enter into the lung where it is oxygenated, and this blood enter into the left ventricle, and the blood which is come from the inferior vena cava enter into the right atrium, and this blood enter into the left ventricle via the ASD, and then to the left ventricle into the aorta. So there is a small amount of cyanosis as the huge increase amount of the blood enter into the lung. So this causing the decreased amount of cyanosis, and this is the Fontan operation in which the blood from the IVC also, that means lower part of the blood from the lower part also enter into the right pulmonary artery, and there from the right pulmonary artery or male pulmonary branch it enter into the lung, and this causing the decreased amount of cyanosis. This is Fontan operation. This is Fontan operation, and this is bidirectional shunt. That is the main, our main motto is to increase the blood flow into the lung. So when there is a decreased amount of blood flow, that means the sinus is there. We have to increase amount of blood flow by BT shunt is the first stage. After the child is cured, then we do the bidirectional plan. That means superior vena cava enter into the right pulmonary artery, and after that we also connect the inferior vena cava with the superior vena cava and along with the pulmonary artery, which causes Fontan operation. Now the Tricuspid Atresia with TGA. That means there is a the blood, the pulmonary artery connect with the left side and the aorta connect with the right ventricle. And restrictive VSD, that means small amount of VSD. So small amount of VSD, what happens? So small amount of VSD leads to small decreased amount of the blood enter into the aorta as the VSD is small. So we have to, what we have to do? We have to do increases the blood circulation by the BT shunt. So we have to do the BT shunt, and after that bidirectional Glenn and Fontan operation. So this is the same funda. And if the blood circulation is increases in the pulmonary blood circulation, that means if Tricuspid Atresia along with TGA with high amount of blood flow into the pulmonary artery, we have to decrease the blood flow fast. That means pulmonary artery bending. Why? Because this huge amount of blood which is enter into the pulmonary blood artery, which causing pulmonary arterial hypertension, lead to pulmonary arterial hypertension, and this pulmonary arterial hypertension decrease causing left heart failure. So we have to do pulmonary arterial banding first. After that, we do the bidirectional Glenn operation. After that, Fontan operation. So these are the treatment of choice, or surgery is the treatment of choice. You have to keep in mind that if the blood flow is there, BT shunt low. If the blood flow increases, the PA bending is the fast. After that, bidirectional shunt in every patient and Fontan operation is the definite treatment of choice. So this is for the pulmonary atresia. Thank you.